So I want to thank Lynn Carsten, who was our gracious host in getting us started. And I want to thank Darlene Johnson. She's in the background. I make sure this meeting runs well, or should I say virtual conversation we're having tonight. So my name is Dr. Swanee Jett. I am the Brookline Public Health Commissioner and moderator for our program tonight. The Brookline Friends of Public Health welcomes you to a virtual conversation about COVID-19, which will feature some prominent public health professionals that are also residents of Brookline and also, work for the town of Brookline. So we're going to sort of have the type of, I guess, program where the presenters will get a chance to speak and talk about COVID-19 and how it's impacted their prospective careers, but also give some in depth about the type of work that they have done surrounding COVID. And I'm sure from a regulatory standpoint, from a physician standpoint, from from the state level, and from the antibody testing level, and also from a regulatory level, you would get an in-depth idea of just the impact of what COVID can have on the community and the type of response that you should expect from a local state health department, but also from the community at large, and in terms of what they are doing and what they will continue to do. So the list of our panelists. Let me start by saying thank you to the panelists tonight. It's a Monday night after a long weekend, good weekend. So it's always hard to come back to work and not have a meeting at 6:30 at night, at least a virtual. So first is Dr. Larry Madoff. He's a physician, medical director for the Massachusetts Department of Public Health. Next speaker will be Patricia Maher. She is an RPN and a member of our advisory council on public health and a retired nurse practitioner. The third person would be Dr. Joe Lenertz. He's an MD, PhD medical director for integrated diagnostics at MGH. And then the fourth panelist would be our one and only Pat Maloney. He's Master in Public Health Administration, and he's the Assistant Director Health Commissioner here at Brookline Public Health Department. And he's an honorary Brookline resident. I must say that. So now we'll start off with Dr. Larry Manoff, and he would speak for 5 to 10 minutes, and then we'll move to the next speaker. Dr. Manoff, the show is yours.
Thank you, Dr. Jett, and thank you all for joining us tonight. It's nice to see so many people and people interested. These video meetings are fun in some ways because unlike meetings that you have in person, you get to meet people's families and pets and see the books on their bookshelves behind them, and it always adds an element of enjoyment to these video conferences, which is different. And you'll probably hear my dog and the folks in the house wandering around while I'm talking. I am home tonight. I have been a Brookline resident since 1993. Both of my kids went through the Brookline schools, and for about the last 12 years, I've worked for the Massachusetts Department of Public Health, and the last year and a half or so as medical director for the Bureau of Infectious Diseases, as Dr. Jett indicated. And this has been a challenging and difficult time, and I preface everything that I say about COVID by saying that what we know today may be different from what we know next week. And this has been true since the very beginning of the outbreak. It's just been such a rapidly changing scene from day to day. Even things are different, and the flow of information. Somebody compared to trying to hold a glass to get a glass of water from Niagara Falls. It's been very a lot to learn, and very humbling because it's taught us the limits of what we can and can't do as doctors and in public health. I also, in addition to my role with the Department of Public Health, I work for a small nonprofit organization that's also based in Brookline, and it's called the International Society for Infectious Diseases. And I've worked for them since 2002, actually, as the editor of the Program for Monitoring Emerging Diseases. And in that role, actually, I was one of the first people outside of China to learn about the existence of the novel coronavirus. And we heard basically through social media channels about an outbreak of pneumonia in Wuhan. And posted this actually just before the first of the year on ProMed. So if you're tuned into ProMed, and it's free, and anybody can sign up to get these email alerts from ProMed. You can learn about emerging infectious diseases all the time. We post not just about COVID, but about all types of emerging infectious diseases. During my career, it's included SARS and Ebola and Zika and many other outbreaks that happen every day. Like many of these emerging infectious diseases, we believe that the virus that causes COVID, the SARS-CoV-2, is a zoonotic disease, one that probably had its natural host in animals and then was transmitted to people, and then became adapted quite rapidly, it seems, to spreading quickly from person to person. And it really became the first large pandemic of this century, and really rivals anything that's happened since the 1918 great influenza outbreak. Here in Massachusetts, we had our first case back on around the end of January, when a student who had returned from his home in Wuhan developed symptoms of illness shortly after his return and was seen at a student health service. Relatively quickly identified and quarantined, isolated, his contacts were identified, and it all happened relatively smoothly. And there were a subsequent small number of cases in travelers that we were able to quickly identify and isolate and identify and quarantine their contacts again, until really early March, when we became aware of a couple of things that really changed the complexion of what we were seeing here in Massachusetts. These events signaled community transmission. In other words, these were cases of COVID that couldn't be linked either to travel or to other known cases. Some of these occurred relative to what I'm sure you've all heard about, the Biogen conference that was held at the Marriott Hotel in Boston. And that included some Brookline residents, actually. But importantly, that spread to a large number of people. Around the same time, we became aware of cases that had no apparent links to travel or to other known cases that appeared in the Berkshire region of Massachusetts. And some of these early cases were really what led us to understand the origins of COVID, and what really quickly mushroomed into an outbreak here in Massachusetts that I was not expecting. And as of this week, we've had over 100,000 documented cases of COVID here in Massachusetts, and over 7,000 deaths. So this has been phenomenal and surprising and challenging, and in many ways heartbreaking to watch unfold right here in Massachusetts. It's been it has certainly kept us at the Department of Public Health extremely busy trying to manage everything from individual cases to laboratory testing that was initially rolled out by CDC and then here at our state laboratory, and then trying to manage a number of outbreak situations, including what's been, to me, the most tragic and hard to understand aspect of this has just been the nursing home outbreaks that have happened around the world, but certainly not excluding us here in Massachusetts, where actually most of our deaths have occurred in skilled nursing facilities, which has been really tragic and really hard to manage, as you can imagine, from the infection control standpoint and through the Department of Public Health. These have been very difficult. We've also seen outbreaks in other congregate care settings, for example, homeless shelters, and in schools and in prisons and jails, which has also been very hard. COVID has, here in Massachusetts, as it has elsewhere, been overrepresented in communities of color and in disadvantaged communities, in addition to its impact, of course, on the elderly and those with underlying medical conditions. And this has been another tragic and difficult to manage aspect of the COVID outbreak here in Massachusetts and around the world. I know you're going to hear more about testing from Dr. Leonard. You're going to hear, I know from Patty Maher more about the aspects of community aspects of COVID. So I will stop my remarks here. Actually, certainly we'll be around for question and answer as the evening goes on. But I will turn it now back to Dr. Jett.
Thank you, Dr. Madoff. Once we get done with each one of the panelists, then we will go into question and answer session. So the next speaker is Tricia Meyer. Please take us away.
Okay. Hello, everybody. I'm a nurse practitioner and a psychiatric nurse, and have worked in the community with disadvantaged populations and communities for about 4 decades, and then decided to retire in January when this COVID epidemic was starting to make itself known. And I felt I had heard in my early career, I was working in geriatrics and had heard so many stories about the 1918 epidemic that I felt that I really wanted to do something, although I was retired, and had the opportunity to do contact tracing with the Brookline Public Health Department and became very fascinated with it. So I just was going to make some remarks about contact tracing and also our experience here in Brookline. So as we're learning so much about this virus from science and public health, contact tracing offers a unique way to understand COVID-19 because it really involves having conversations with people affected and supporting those people and engaging them to help in stopping transmission. And it has allowed us all to understand this human experience of a pandemic, how COVID-19 is affecting us all, the people who are sick, the people who are caring for the sick, and the people who are exposed to the sick. Contact tracing has been and it remains very important in controlling many infectious diseases, including measles, tuberculosis, hepatitis, HIV, and others, and historically has been an important part of public health. Even 100 years ago, contact tracing was used during the 1918 flu epidemic, although at that time little was known about viruses because they were too small to be seen with the technology of the day. But it was known that something infectious was being transmitted from person to person. And as Brookline nurses and doctors cared for sick people up in an outdoor field hospital on Quarry Hill in Brookline, public officials, health officials worked here to stop transmission with the familiar and effective public health measures we have today, isolation and quarantine, which are really the tools of contact tracing. Also hand washing, masks, use of disinfectants, and limiting the number of people at public gatherings. And these measures then in 1918 were carried out unevenly across the country, much as they are today, unfortunately. But what about contact tracing with COVID-19 in 2020? Now that we have so much better science, we have more public health knowledge, computerized data, mathematical modeling. But with all these advances, the importance of the person-to-person communication that is part of contact tracing, I think remains essential, because becoming ill with COVID is a really frightening experience, and remaining isolated and quarantined is very difficult. And people need and really appreciate the support and guidance given by the contact tracers. So as important as it is, contact tracing is only one public health measure, and in order to be effective, it needs to be part of all public health measures. And in addition to the measures that I mentioned in 1918, we do have testing now, which goes hand in hand with contact tracing, and which we'll need more as we open up. Also, the possibility of contact tracing apps, may be an option if the privacy issues can be worked out. But as news of COVID began to reach us here in Brookline, I want to really recognize Barbara Wesley, who's the Brookline public health nurse, responsible for leading us as contact tracers, training us all, answering our many questions. And she actually became involved from the very start with the person that Dr. Madoff mentioned, our first Massachusetts COVID case, the young student flying from China to Boston. One of a Brookline resident was on that same plane, and Barbara quarantined, monitored her for symptoms, and after 14 days, she was found to be healthy and she was released. So that was in early February, and by early April in Brookline, when I began to volunteer, there were as many as 20 cases a day being reported in Brookline. By that time, Dr. Jett had mobilized the public health response, and Barbara Wesley had trained 14 of us, 14 new contact tracers to assist her. She found people from other departments in public health and also school nurses willing to help. So at the same time that Brookline was gearing up, the state public health department was also rising to the challenges. They revved up their computer system to handle the 100,000 COVID cases, and they recruited and trained 900 contact tracers with the Community Tracing Collaborative to support towns and cities who needed additional help. With Brookline, we have all the help we need, but there are many towns and cities that really need additional help with contact tracing. So where are we now in June? To me, I've been so impressed. We are in very good hands with our local and state public health departments. In Brookline, our cases are way down, and in the state as well, they remain pretty low. But as important, as effective as the public health measures have been, the public has a very important role. In a Globe editorial last week, 2 global health experts wrote, "We are not helpless in the face of this virus. We know a lot now. The shape of the second wave will be the direct product of our collective actions." And those actions, just to remind us all, because they are really going to get us through this: social distance, to assume that people around you could be infected without knowing it, because the evidence suggests that 30 to 50% of cases come from pre-symptomatic or asymptomatic spread. To wear a mask and encourage others to wear theirs properly. Think of masks as interim vaccines, the best thing we have, because evidence suggests that if 80% of us wore masks, total infections could be reduced by a significant amount. Wash your hands, stay home when sick, and answer the call to stop the virus. Work with the contact tracers if they call. So in closing, I'll just say a few words about the other epidemic we are facing, that of racism, because all of us who have been doing contact tracing here in Brookline have been really inspired by the willingness and generosity of Brookline residents to follow isolation and quarantine recommendations and to share their experiences with us. And many of the people we've talked to have had a similar message. They tell us we are all in this together. And yes, in so many ways we are in this together, but it has also become very clear that we're all in it together, but not on an equal footing. And what has emerged at this time of this terrible epidemic is a long overdue recognition of the terrible reach of racism and systemic inequities. And that recognition is compelling us as Americans in unprecedented numbers to work towards combating these two public health crises, racism and COVID, that are co-occurring. So, as the public health experts tell us, the future will depend upon our collective actions, and we must keep hope alive, remain vigilant, and stay active and engaged for the long haul. And I'll end there.
Thank you. Thank you. So our next speaker as we move forward is Dr. Joe Linares. And I would turn it over to you to, talk to us 5 or 10 minutes about what you have faced with COVID and what you are currently doing.
Of course. Thank you for having me. I can just second what both of my prior speakers spoke about, and I want to maybe briefly outline what a world pandemic looks like from a laboratory medical director's perspective, because that's really what this has turned into, a large discussion as well as challenge from how to correctly diagnose this disease. Now, we all know that COVID is the disease that's caused by SARS-CoV-2, which is the virus, the underlying pathogen. And basically the entire field was confronted in late 2019 in the world, but I think here in Boston, particularly in February and early March, to say, how can we test for this? Now, to give you a brief encounter, after identification of that sequence, meaning the genetic blueprint of this RNA virus, actually at the Wuhan fish market, that sequence was rapidly distributed across the world, and several groups have developed primers, which are these little biomolecules to amplify a part of that. And the CDC kind of locked it down in one assay, and that was then the common approach. The problem that all the labs basically all over the States faced is, how can we actually implement this test? And because of concerns for various reasons, the FDA stepped in and said, we want to make sure that these tests function appropriately, which I think is the correct approach for this, to not have all kinds of people do all kinds of assays. Now, while that sounds like a well-intended effort, that also means suddenly everyone has to hold themselves accountable to FDA standards, which is great. So we had to have this test, because of inpatient concerns, but also just to know whether a patient presenting with respiratory symptoms has that. So we submitted our test, which is a version of the CDC assay, to the FDA and got our approval as the 4th lab in the country on April 3rd. And from that moment on, a few days before due count, we started testing, and we saw what Dr. Madoff was just saying, the peaks. We tested some of these nursing homes, and we were absolutely shocked to see the rates. Basically, from that moment on, the rates keep increasing from an initial, oh yeah, we actually see a case, to basically conversion of many inpatients as well as some of the outpatient settings to have high rates of positivity. Now, at the same time, it became clear that there's a huge demand for public testing for various reasons. Number one, just because everyone wanted to know. And then secondarily, what to do. You heard about contact tracing. But from a laboratory perspective, it starts with that you have to have the index case. Otherwise, you can't do any contact tracing. Now, imagine you do contact tracing and it is a false positive case. So clearly, having reliable tests is absolutely critical for any of these endeavors, because otherwise, you're chasing a ghost, and that is never good. Now, the key element here is that we know that many people can clear the infection, some with symptoms. And it has become clear over the last couple of days that some also they remain asymptomatic. They have it, clear it, and just remain basically healthy throughout. Now, that poses unique challenges because you can't really tell when someone had it. So nonetheless, that means that the detectability of this virus by RNA changes over time. So if you assume you get it one day, you may or may not have symptoms, but then the rate of detection goes down over time. And that became relatively clear over the first couple of days or weeks that we saw patients with this disease. Now, that immediately raised the question, well, if someone is clearing the disease, do they mount antibodies? And we jumped, obviously, immediately at this test that's called serologic tests. And we got the okay from the FDA to use this test on May 12th. And one of the things that I want to point out here is that in collaboration with the Brookline Department of Health, we conducted a public testing. And I think, we've done quite a few of these in the meantime, but I really want to give, some huge thanks and a big high five to the team in Brookline, because I may want to explain why, to this day, the design that we did in Brookline is still groundbreaking. So one thing is, everyone heard about the PCR test. That's the test that I just illustrated. And the test for the antibodies or serology is the one that, can indicate whether you're infected now, but more importantly, whether you've been exposed. So from a public health perspective, to know where a town, a city, a group, or any cohort stands at any given time, antibody testing is much more meaningful. So in collaboration with several people and Dr. Jet, we designed this particular screening in Brookline in a very, very interesting way. So first, there was a debate who to test. And the first responders was one of the group that is obviously the highest and most vulnerable, because they have to have, by being essential workers, contact with the public constantly. In some cases, let's pick, for example, health professionals, emergency medical services, they have to touch people. They're in very close contact. So they're at the highest risk from a contact perspective. So we dedicated a subset of these tests that were at the time really rare and extremely expensive. And supply chains were extremely limited. So we had to come up with a very reasonable and at the same time powerful design. So the first part was basically dedicating that to about 150 tests for the first responders. The second part, drawing from the huge experience of Dr. Jet and the entire team, was to really look at a randomized subset of Brookline residents, because Brookline as a town is epidemiologically very interesting. And I'm sure Dr. Jet can maybe later on explain a little bit why that's so important. But the randomized subset from an epidemiologic perspective doesn't just mean random. It means that it should accurately reflect the entire population. And that draws from the huge experience of the Department of Health. And we dedicated another subset of tests for this second group. And then, because of enrollment and how the testing was conducted, and Chief Sullivan and team, Dr. Jet and team, everything worked very smoothly, we allowed on the second day just basically random walk-ins. And in that case, the random means really just people on the street, whoever was available. Now, by chance, or maybe by a sign from the higher powers to be, interestingly, all three groups were almost identical size. So we had 210 first responders, 150 roughly randomized subset of people, and then the population that just showed up was about 340. So yes, there are some differences, but total we tested about 700 people. For the time, 2 days, that's extremely impressive from a throughput perspective, giving big applause to the conduct, but then also it gave a very unique insight into the stratification of the population, meaning the first responders, which should have the highest rate, then the randomized population, and then the population just walking in. And the rates were not statistically significantly different, so they were all the same, which has several implications that I also want to share briefly. First responders were about 7%, the population randomly was 7 to 8%, and then the free walk-ins were about 6 to 7%. So that indicated that we were below some of the other neighborhoods, meaning the exposure was probably slightly lower. But another element of this analysis is also that the first responders in particular, but also the population, likely used contact precautions appropriately. So what we learned is that while, for example, from an age as well as gender distribution, Brookline shows the exact same characteristics. I think from a design perspective, for a 2-day concerted effort, we learned quite a bit epidemiologically. And just to keep in perspective, from the planning, etc., just to give a high five to the entire team, because that was really incredible. We planned this on the 26th of April, and we were done with acquiring the data on May 16th, which is incredible. That was the fastest and most organized, testing that we've done in such a small time, getting such a critically important piece of data together. And with that, I like to turn it over back to Dr. Jett, and I hope that this was a good summary of what we've done, where we are right now.
Thank you, Dr. Nurse. Well, first I want to give credit to the whole MGH team and to Fallon that worked in our EOC and our EOC staff, because it wouldn't have happened without the effort, without the planning process, and a little bit of pushing the button at the last minute and allowing people to show up through the methods of Facebook and blogging, which actually pushed our numbers up and made it more impressive to be able to handle that throughput. So we have an idea of what we can accomplish now. And, I was just happy to be able to provide it to the citizens. And I'm definitely blessed that MGH signed off on it. And so, yeah, thank you. So our next speaker is the one and only Pat Maloney, who is retired, and I brought him back just to help me with COVID, and then I'm gonna let him push his way back to retirement. He's Assistant Health Commissioner in Brookline, has worked for Brookline for 38 years and public health for 40 years. And so, we probably have to keep an honorary desk here for Pat and retire the desk. So take it away, Pat.
Inviting me and making me an honorary Brookline resident. Yeah, I've been here for 38 years and started as a part-time sanitarian, worked my way up to full-time, and eventually, as Dr. Jett said, the deputy commissioner position. My position oversees the environmental health division for the town of Brookline. That's the inspectional arm, the code enforcement, the regulatory, and education. We do education, permitting and licensing. So I look at us, we have a team of frontline public health practitioners. Very fortunate to have a great team, well educated, well credentialed, and as you'll hear, very versatile. Um, Being in Brookline for so many years, seen so many things and evolutions, but um, this was a real challenge. This was, I was asked to come out of retirement. I retired in November, and but this all of the tools that we need as a practitioner together to really do the job that was needed. Uh, One example is all of the environmental health staff. From day one, Dr. Jett had them immediately become contact tracers. And it was a brilliant move because it assisted our public health nursing with supervision of everyone. And it was challenging. The number of cases that were coming in initially were fast and furious. And our staff, uh, they're most of them are masters in public health, and they've been trained in epidemiology. So this was a smooth and easy transition for them, and it really strengthened our response. We were meeting every week with boards of health across the state on webinars, and I was hearing time and time again how other cities and towns were struggling with the contact tracing, and we jumped on it right from the get-go and transitioned staff to do that. In addition, having the school nurses also were a tremendous assistance. So we put together a great team from the get-go, and I think it helped us as it's evolved. Um, Public health significantly changed for us. We had to stop all of our routine activities that we do in the environmental health division, and it was all hands on deck for what was coming. Well, As you know, the governor phased in the reopening of Massachusetts into 4 phases. And it's really more than 4 phases because right now we're in phase 2, but phase 2, step 2. So I think when it's all said and done, we'll probably have about 6 phases with the additional steps that are going on. But we had to stop doing our routine assessments and respond to the calls, the inquiries, any questions that were being received at the health department. All of our frontline clerical staff, they had to go through training and reviewing of what was expected of them. Dr. Jett put me on the committee with the emergency response team, and I was titled as the deputy commander for the EOC in public health. And that was a tremendous team, as you previously heard, put on the immunization, the screening clinics that we did. And um, it really was, it's a, has put together an emergency preparedness team. While we were doing that, we were getting calls from cities and towns across the state. How did you do it? Phone lines together. How do you? And it was troubling to get those calls because they hadn't planned as we did. And you can't tell somebody in 10 minutes or a half hour how to put together an EOC as we did. This was many years of preparation. It's been used for a number of other emergencies, but this true pandemic here was really, it put all those elements that we've been working on for years in motion. So I commend the town for having the vision of putting together such a center and putting together a team. It's not just the health department, it's the fire department, the police department, public works. Everyone was part of this, so very important. Um, you know, Brookline's always been the first with many things. First on tobacco control, first a number of bylaws and regulations many states have followed. And I have to say, uh, one thing Dr. Jett did right away was he mandated face coverings. We were doing that in Brookline before it started, before any city or town. And I think, as we see now, that was a very important decision. That was a very important step to take. We took a lot of heat about it, and I'm sure Dr. Jett will mention that, the amount of heat we took, but it was a necessary thing to do, and it turned out to be something that I think people will appreciate. And many cities and towns called us asking, how do we do it? How do we word it? And they all followed suit, and eventually the state followed suit. So that was a good move, a good step in protecting the public health. At the local level, we can do things very quickly. It's one of the more powerful departments, the Board of Health. And that's what we did. We exercised our powers as a Board of Health and did what was necessary to do that. For our environmental staff, as I said, things had significantly changed. Every time you hear the governor announcing a new phase, a new step, all of the oversight, enforcement, and follow through comes down to the Board of Health. The phases that we're dealing with now, the opening of the restaurants, the outdoor seating, the interior seating that's allowed. We at the local public health are the ones that give the guidance, the education, and the follow-up monitoring to make sure that these standards are being followed. And I don't think that's mentioned enough. People don't realize it. The governor and the state mention what is needed, what needs to be done, but who does it? And we at the local level. So I think we're very fortunate to have a staff, as I said, well credentialed, well trained, and these transitions have been, for the most part, as seamless as you could hope for. At the beginning, it was bumpy because of the change that people had to understand the face coverings, the social distancing, and the grocery stores. They were a challenge initially, but once we went out, educated them, did some hand holding, did some monitoring and follow up, it all fell into place. And I think you'll see as you go out and about the town, all of our establishments have been doing what they need to do to work with us to protect the public health and ensure that their customers and their employees are properly protected. But it was challenging, and luckily we have a good team that let us get there in that direction. So with that, I turn it over to Dr. Jed, and perhaps if there's some calls or questions that people want to pose to us.
Well, thank you, Mr. Maloney. And first, first I want to say, thank you to the group, and because everybody gave a snippet. And I would just tell you, so even though I'm the health commissioner, the Brookline Public Health is very lean. So I've often been a worker bee. And it wasn't until Barbara, speaking to Pat Moyer, Barbara actually went on vacation to Spain. Um, and, we have been quarantining people since January, but we hadn't had a case yet. So we got the first two cases on a Wednesday. And I was in the media talking about, we at low risk. And I was talking with the superintendent of schools and suggested that we close for 30 days when we got two cases. And I really didn't understand the impact, but I said close for 30 days, we'll know more information. We were originally talking about closing for a day or two. But then the school board decided to close for 15. So we agreed upon that and I spoke. That was a Wednesday. Saturday, I was in Florida and I was the only other epi that was in charge of tracking the cases. I allowed my other two staff to deal with everything else that we actually do, contact tracing on epi work. And so Saturday, 9 o'clock, I get a call, a couple of emails, and boom, I have four cases. Um, 13 people had to quarantine, and I was on the call on the phone from 9 a.m. to 1 o'clock p.m. and nobody at my house at 8. And I was supposed to taking everybody to breakfast. So I knew I was in trouble then. And so immediately when I got back to work Monday, I said, we got to shut down our operations. And everybody, um, you know, all staff, we have to take calls. We can't do inspections no more, all environmental staff. We have to do epidemiology work and we have to train everybody up. The school's going to be closed. So, I asked the school coordinator, Tricia Lim, said, is it possible that nurses would want to do this or volunteer? And that Monday morning actually kicked off what I would call our department operations center. And so that we can respond to COVID. Prior to that, I had already been wearing a mask through the airport. So I was ridiculed by a lot of people. I started wearing masks in late January, February, everywhere I flew. And so I began to think, you know, at that time period, because I saw the ProMed reports, I was reading the WHO reports, and I read the WHO report that worked on, they did a joint effort with China, and they had 56,000 cases. And I said, if we don't close our borders today, which at that time was early February, the United States is very global, diseases travel. So I remember from in Florida working on SARS, MERS-CoV, working on Ebola, and how I had to lock down a plane at one point. That number one, everybody needed to wear a mask. But I know at that time it would be challenging. I thought three things, and I'm gonna open it up for Dr. Madoff or Dr. Nurse to think about this. I thought three things would have reshaped the U.S. and we wouldn't have had no deaths. Number one, if our messaging would have stopped all travel from China into the U.S. and people from traveling from the U.S. to China because we had 18% Asian population. There was a lot of travel happening because I was quarantining people. So that was one thing to have done that early, either late January, early February. Two, to shut down the U.S. for 30 days to allow at least 2 cycles of COVID to pass through. And three, if anybody left the house, they had to wear a mask, and that was mandatory. Do you think if we had a public health response like that, it would have made a difference? And so I opened up Dr. Madoff. I know this is looking hindsight, but I was saying this back in January, February, that it would have made a difference. Of course, I might have would have been around because it was such a bold move. But what do you think about that?
Um, Dr. Jatu, should I try to? I'll take a plunge at that. I think if you look today, there's COVID in essentially every location in the world, and we are an incredibly interconnected planet. Um, you have a situation where you have a disease that can be incubating, inapparently for up to a couple of weeks, and we know now that many of the people with the illness are also asymptomatic, at least for a portion of their illness. The history of trying to contain outbreaks through travel restrictions has not been successful on the whole, and people manage to travel despite restrictions. It moves migration underground instead of overground, and the fact that you can travel anywhere in the world in less than 24 hours it makes it very difficult to use travel restrictions to contain an outbreak. Um, I think that was an early response, but even that response was partial. As you know, I mean, travel was shut down to some extent from China, but not completely. And it's very difficult to contain an outbreak that way, just because the borders are porous, and we know how easy it is to cross borders. And even when you shut down, there's still some people who are allowed to travel, right? There's still the military, there's still government folks, and then there's illicit travel. So travel restrictions for an outbreak like this tend not to be effective, and I think that's what we've seen not only here, but really that's why there is COVID in every populated part of the world at this point. Your second question was about shutting down. And again, I think that may have had been a way of approaching it. That if when you don't have a vaccine, when you don't have a cure, all of your measures are as Patty alluded to, really based on isolation and quarantine. And if you can decrease mobility sufficiently so that you can reduce the reproductive number, which we've all heard a lot about lately, are not effective are to below 1, an outbreak will die out. And if we can use social distancing, if we can use isolation and quarantine, then those measures can be effective. And maybe if we had done more sooner, we could have stopped this from being as large an outbreak as it was. I think, we saw that in China. At the time the outbreak was happening in China, there were 80,000 cases. That was a staggering number of cases, even in a country of over 1 billion. But we've now, we have 20-fold more than that here in the U.S. So perhaps those kinds of dramatic lockdowns could have worked here. We won't know. We don't know.
And my other question had to do with the requirement of masks. So, we decided to leave, and as we've seen, every state has done a different public health measure. I personally thought that, requiring everybody to wear masks, even if you were asymptomatic, um, would stop the transmission of disease. Even when I screened people in Africa for Ebola, I wore a mask. I wasn't sick. Didn't know if they were sick or not, but we use it as a precautionary measure. So, um, why do you think the messaging on mask occur? And I still see it occurring now in the media in different communities as well.
So again, and just speaking in my opinion, I think the evidence is accumulating that masks are an effective measure of reducing transmission. I think we didn't know that at the beginning of the outbreak, and that's why you saw mixed messaging on this point. We know that there are settings where masks are highly effective, and your surgeon wears a mask. Healthcare workers know how to use a mask in conjunction with other infection control methods, and so mask use can be highly effective in some scenarios. And we didn't really know how beneficial it would be. And I think the evidence is still not completely in, but I think the evidence is accumulating that masks are helpful. And again, perhaps not completely preventing transmission, but in reducing that reproductive number so that in combination with other public health measures, they can be effective.
Okay, we have a question that has just come in. A resident wants to know how safe are masks that have valves?
So it's an interesting question. So masks, as I mentioned, masks we're used to. Our habit is to use masks for healthcare workers to protect them from exposures in the healthcare environment. And for that purpose, masks that have an exhalation valve that allow breath to travel freely out of the mask while restricting entry of air to be through the mask are useful in preventing someone from getting an infection, from preventing particles from going into the recipient. But a mask that allows exhalation is less effective as what we call source control, preventing someone from spreading an illness. The same, by the way, is true of the what are called PAPRs, the purified air, the powered air purifying respirators that are used. Those also protect the wearer, but they actually blow the person's breath out of the apparatus. So they're not useful as source control. So I would say that those masks with valves are less effective as source control. They're probably not completely ineffective, but they're less effective. You prefer not to use them for that purpose.
Going to the next question, and this is from Emily Green. Is it possible that asymptomatic positive carriers who will continue to shed the virus for a long time, similar to Mary Maloney, the infamous Typhoid Mary, who infected thousands of people in New York from 1906 through her death in 1938?
So I temper everything I say with what I said at the beginning, is that we learn a lot about this virus every day, and we certainly don't know everything that it has to teach us. What we have learned so far is that the overwhelming majority of people who become infected with the virus and recover from their infection, meaning they get well, they clear the virus and they don't continue to spread it beyond usually about 3 or 4 days after their symptoms are gone, or after their symptoms improve, after their fever goes away and after their cough starts to improve. They develop antibodies, as Dr. Leonard says. They probably also develop other forms of immunity, cell-mediated immunity, that protect us and allow us to recover. And so while you can detect little elements of the viral RNA for a long time after people clear the infection, it appears that the risk of transmitting the virus to others goes way, way down within a few days of recovery symptomatically. So that does not appear, long-term shedding does not appear to be a common phenomenon, at least in most people.
So next question is from Paul Harris. Says, thanks so much for all that you have done. Yesterday, Massachusetts ranked 31st of all states in new cases. Great news, but it ranked second in new deaths. Why does MA rank still so high in deaths and new deaths?
That's a good question. I'm not sure that's true. As I read the statistics, we were down to I believe under 20 deaths in the state, which is still, of course, a substantial number. But I think that we've fallen in the rankings, fortunately. I will say that we peaked late here in Massachusetts compared to other states, and so far, and we're starting to see later peaks in some of the southern states that we're now seeing: Florida, Texas, and Arizona. We're having some alarming trends in their virus. But there are a number of factors that impact deaths. First of all, deaths are a late phenomenon. So first you catch the virus, then you get sick with it, then you go to the hospital and you might get sicker, and only sometimes weeks later do you succumb to the virus and death occurs. So death is a lagging indicator. It happens late in the process, and you may still be seeing deaths due to infections that occurred weeks ago. And of course, deaths also depend on the population, the comorbidities and the demographics of the population. And we certainly see comorbidities, including heart disease, lung and liver disease, immunocompromise are major risk factors. Again, we see excess of hospitalizations and deaths in disadvantaged communities and poor communities and populations of color. And certainly we saw many of those factors come together in our skilled nursing facilities and our nursing homes, where we saw people who were older and with multiple comorbidities who succumbed, and that certainly accounts for the death rate in part. My son is currently living in Dubai, where virtually they have a fairly similar number of cases to what we've seen here in Massachusetts, in the tens of thousands, but they've seen almost no deaths. And I think part of the reason for that is that there are basically no older people in Dubai. People work there but don't retire there and live there. There are very few old people. And so deaths have to do with a lot with the underlying population, as well as with the spread of the virus.
So I'm going to go to the next question. I'm going to pop in because I know some people got some very intense questions. So Pat, Maria, this question is for you because you've worked in mental health. And can you talk to us a little about the psychological aspect of being isolated during COVID? And, what I'm noticing now is I think we've have COVID fatigue. And so people are doing their own internal risk assessments on, well, I've been in house this long. I think I'm just going to take the chance and let's go to a bar, let's go to the beach. Or so, how do we balance that?
Yes, that's such a good question. That's such an important question. And, if you just think back 3 months ago when this virus started and it was so unknown, there was so much uncertainty. And I think there was also a lot unknown about us and how we were going to manage this. I mean, when we heard about China shutting down an entire city, it seemed inconceivable to us until we sort of shut down our entire culture. I don't think that we knew that we had that in us, but the amount of fear, uncertainty was very high. And also, you know, to say that it's so unpredictable. You could have a disease, you could become positive with COVID and have no symptoms, or you could be in the intensive care unit on a ventilator, you know, struggling for weeks. So I think added to that is all of a sudden we're all by ourselves. Some people completely by themselves, and other people with their families, which, you know, could bring up past problems, stress, domestic violence, add to the pot economic problems. And it's a perfect stew for high anxiety and, you know, very troubled psyches of all of us. But I think as it opens up, we shouldn't be afraid and uncertain, because there are definite public health measures that we can use to reach out to each other again. And I know that people have been doing it virtually, but there's nothing like, you know, being outside in nature, being with other people that we know, starting to see friends again at a distance with masks, making sure we only go out when we're well. And so I feel like we're uncertain, we're fearful, we're isolated, we're tired of it, but also we should feel there's been an explosion of knowledge. Even though there's a lot we don't know, there's a lot we know about this virus, the incubation periods, the fact that it's asymptomatic, and all the things that I mentioned in the talk, I think can make people safe when they go out. The distance, the masks, the and the staying outside as much as possible and not being inside.
This question is for you, Dr. Lenert, and it's just something to ponder about. And you know, I'm a person that when COVID first in the impact Brookline, uh, I had never experienced a death on my watch as being a local health commissioner. So it kind of stunned me pretty good. And I'm always the aspect of preventing mobility, but more mortality. And so, you know, we're going back to sports now, um, and we started to see a number of cases. We are reopening, and we don't have a vaccine. So, you know, can you give us a best estimate? Because I've never believed 12 to 18 months it takes that long. I always thought, I remember H1N1, it was 6 months when we had a vaccine. How close are we to a vaccine? And should we wait for a vaccine before we really get to phase 4 in any community, or phase 3 of reopening?
Um, that's a fantastic question. I'm not an immunologist, nor am I, in the business of developing a vaccine. What I'm directly involved with is, identifying some of those patient populations that are likely going to be, most impacted by it. So in contrast to some of the other diseases that are also infectious that you mentioned, the question here becomes, because of the close homology between some of the SARS and some of the other beta coronaviridae, which are in the same sort of genus, is whether these vaccines will be not safe from are they protective, but also will they react with some of these other viruses? Now, when looking at the other beta coronaviridae, we have all probably seen those. The prevalence in the population for some of these other, common, coronaviridae is 96% or so. So the actual challenge for developing some of the vaccines is to identify regions of the virus, of this specific SARS-CoV-2 virus, that will trigger our immune system, obviously without causing a disease, without showing cross-reactivity to all these other viruses. And that is one of the challenges. There are some very, very smart approaches to genetically engineer some of these individual components together so that we can move forward. Nonetheless, I think the the extent of doing that in an ongoing pandemic poses enormous challenges. For example, we spoke earlier about travel restrictions, etc. The key problem is that some people don't have symptoms. When you talk, about a, diarrhea or some disease with like a clear-cut clinical picture, the screening can be done relatively quickly and efficiently. But just from a trial design for a vaccine perspective, judging by the common, like current knowledge, that you could have a 14-day incubation period and you may or may not shed the virus for 4 to 5 days, and you need about another 10 days to mount the immune response. We're talking about a rough 3 weeks to fully and clearly determine whether someone does not have this SARS-CoV-2 virus while being exposed, for example, in a clinical trial setting in that healthcare facility. So that poses unique challenges to, a trial design. And I think that is what's needed. Obviously, there's also, if we say that is the pro aspect for the safety of vaccines, there's also like a lot of other things. It's a highly competitive field. We've seen so many diagnostic tests emerge. In the meantime, there's, over 200 serologic tests and probably more being developed. So I think this is a new challenge with, rapidly emerging innovations, and at the same time, the industry and the tech field itself being able to move so fast. It's almost like to be how to select between these things. So I don't want to be in a position of the FDA reviewers, right? They are completely swamped. Everyone's working on this in parallel, and everyone thinks to have the breakthrough. So the question is, while we transition into, a phase where, more collected and calmer decisions have to be made, how to maintain momentum and deliver safe and effective vaccines. That's a huge challenge. So I don't know whether that's a direct answer to your question, but I think those are some of the aspects that make SARS-CoV-2 somewhat unique in that aspect.
Thank you. I'm going to answer these two questions that we have now. Has the town any plans for testing the approximately 500 seniors who live in Brookline public housing and do not own cars? Well, so we are right now planning to test not just seniors. Um, we are looking at Brookline housing, but we're all looking at also Hebrew life. Um, and we want to also expand and to make sure that we can, cover the uninsured. So, as you know, with COVID, just as natural disasters or any other major disease that happens in the U.S., it always impacts the minority populations at a greater has greater impact, and the social determinants of health become more obvious when you begin to drill down and you look at the numbers, and you begin to see the uglies of society, the health inequities. And so I could almost anticipate um, in February when I had a colleague to tell me COVID is not impacting the African American community. And I said, well, initially, no, but wait on it, because a lot of people are not doing travel overseas. But once it gets into the United States, the most vulnerable parts of society, especially when you're not in work, um, we have shut down. Many of our workers, our frontline workers, are getting it first, and hospital workers. And so, when you look at COVID and now you look at the protest, it's almost they happen simultaneously, and it's impacting African Americans greatly right now. And so we're going to get to testing in Brookline housing, but also I think we have to really begin to look at our vulnerable parts of our population and make sure we provide the appropriate testing to them. And you know, while I'm on that subject, I'm going to ask Pat Maloney a question because I think it has come up before about protesting and wearing a mask and social distancing. Pat, can you give us, your thoughts on that?
Well, I think it is an important element in some states and some municipalities, they've actually assigned public health workers to these events to educate, distribute face masks, and do what they can to prevent further spread. Um, when you just everyone has seen it on TV and media coverage that unfortunately some of these events persons are oblivious to the social distancing that we would want to see. Other events, fantastic compliance, face coverings, social distancing, uh, you know, listening to the event, and it works well. So I think, and we've had some comments, we get all the calls coming in to us, and many people have communicated with us saying, you need to put up more signage. You need to make sure persons that are marching or protesting do follow the social distancing. But I have to say, from what I've seen in Brookline, fantastic compliance. It's been in other jurisdictions that some more work is needed, and I'm glad when you do watch where it gets stressed, it gets mentioned. There should be social distancing at these events because it could contribute to the spike that we're trying to avoid. So I think it's an important element to add.
Yeah, and I would just add to that. There's an article in the paper that actually, it was in the American Legion Journal that it said we are glad that San Francisco did not win the Super Bowl, because if they had won the Super Bowl and there had been a parade, that there was going to be it would have been a lot of people out there that possibly would have gotten COVID, such as what happened in 1918. There was some type of gathering or parade, 200,000 people attended, and it actually spurred more people actually contracting influenza. So our next question, and it looks like it might be for me. Do you anticipate the need, that's from Susan Granoff, do you anticipate the need to hire more contact tracers once the schools reopen for on-site classes? Each high school student, for example, might come in contact with hundreds of students each day, which would require a lot of contact tracing. So, to answer your question, Susan, initially some of our first cases actually started in the schools, and we were able to manage it with the current staff we have. So we didn't hire any contact tracers. We actually converted our staff, because it's part of their things that they've learned in school. Um, and at some point in time, if as we reopen, if the cases begin to mount, the health department has to stop doing what it does normally in terms of inspections, and we have to focus our efforts on doing the epidemiology work for COVID.
And if I can add to that, you and staff have worked very closely with the school department and schools within the town to address concerns, answer many questions. The recent graduations, I mean, we were on the front line assisting them to to ensure that these went off as safe as possible. And so behind the scenes, public health is assisting and educating so that these events do occur. And I know will be put on task when schools open. We're already getting questions, and that's quite a few months off, but we're trying to pre-plan for that.
Thank you. So I have another question, and this one's from Jared Orsini. What planning is being done currently uh, by the department to prepare for the second wave to try to keep case counts low as we reopen over the next 2 to 3 months? Whew. Pat, do you want to give that a stand?
So it's a continuation, where we're looking. We've lived through this phase, and we're hoping we don't get a second phase. But we do have our EOC that we can reinstitute, and watching things very closely. We do get nervous with the phase approach of opening businesses and opening more to the public. So the key is with our partners in DPH and monitoring what's going on in the hospitals, what's going on, what our contact tracers are seeing. But it's a continuation of our plan, and it's not, we're not letting up. We're still keeping it to the grindstone there.
So I think to further answer that question, this might um, move it to answering the next question. So I think the main key for the department moving forward is our messaging, um, making sure that we require people to wear face masks, not only the business, because we were the first to require business to wear face masks as well, and then require the citizens to wear face masks. And if they do, wherever they shop, I remember early in when COVID happened, we noticed that there were an increase in cases all of a sudden coming from places like Trader Joe's or Whole Foods and CVS. And we said we got to require masks because we have shut down everything else, and now these are becoming the hot spots where people are not wearing masks. One, because they think they're asymptomatic and they're not spreading, but two, the business not wearing masks. And so I think the constant planning for that, making sure we wear masks, making sure social distance, making sure that we can track people, um, our education, you see signs everywhere. And so I think we're going to continue with the lawn signs I see, and just educate the community overall.
Can I would just, Dr. Jett, sorry. I would just say too that when we're contact tracing, we consider a close contact only, which means that somebody that has been within 6 feet and for longer than 15 minutes. So it's really helpful to kind of keep that in mind, to stay 6 feet apart. And especially, you know, if an interaction's more than 15 minutes, then it starts to get into close contact. And if you're 6 feet apart with both with masks on, you know, you can consider it safe. And one example that the public health department has been totally instrumental in helping the farmers market open this spring. And, you know, with that safe distancing, masks for everybody, and hand washing, and really good education of the vendors and the people who shop, it's been a real success.
Yeah, I have to give a plug to the farmers market. The market master did an outstanding job of working with us, and he came in with a game plan incorporating health and safety protocols that uh, you know, he presented them to us, and we just fine tuned it a bit. But they did an outstanding job, and we're very comfortable with that event. The other thing I want to mention is behind the scenes, you know, establishments are obligated to report to us, the ones that we regulate, if they do have an upswing in or any ill employees. And as Dr. Jett will know, we had a couple of occasions where we were concerned about a possible cluster. You probably read in the media where a large retail establishment outside of our jurisdiction had over 80 employees ill. You know, more than a cluster there. So that's something that's what we're doing behind the scenes, communicating with all of our establishments that are open, reminding them of their obligation to report to us. And if we do see a trend of staff that work there coming down ill, even though if they don't live in our jurisdiction, they're working in it, we look at that very closely to see do we have to take steps to appropriately protect the public health.
So next question is from Lauren Kane, and at first I give a shout out to her. She helped me with some of my empty charts and work. Um, and she's an epidemiologist. She has a question for Dr. Nurse. Dr. Nurse, can you talk a little bit about how the tests are evaluated? It seems more challenging to determine the sensitivity and specificity when the proportion of asymptomatic cases is so high.
That is a very good question. So we can't even really identify true asymptomatic patients because, you know, we see ton of patients that come and said, I had something in early February. Can you test me and see whether I had it? So, this is like, asymptomatic versus symptomatic gets back to one of those core principles that symptoms are subjective things, right? You can say, I have a headache, and no one can prove you right or wrong. So that's just sort of a very fundamental principle of identifying whether someone is symptomatic or not. What we can do in the laboratory, and that's how we validated the test, is that we can go back in time and pull, for example, serum back from January 2019. So basically last year, January, to say, we have the serum frozen and we check. At that time, the virus was just not introduced into the, human, existence. So it cannot be there. And then we can get, for example, if any of the tests would show up a positive, we know it would be false positive because at that time SARS-CoV-2 was just not present in the serum. And that is how we can get at least towards the specificity of a test, meaning the rate at which you detect something's false positive. Sensitivity is much harder. So for example, at the time of infection, when you acquire the virus, yes, it will be there and you can detect, the DNA or the RNA using PCR. Over time, however, that decays. So the sensitivity, as well, as the sensitivity of serology, is a function of time, whereby, as the virus goes down, as you mount an immune response, your serology comes up. So at time 0 of your infection, you will not have an immune response detectable, but that ramps up. So the sensitivity of a serologic test very early on will be much lower than later on. So both are basically kinetic curves. And by doing multiple tests either over time or multiple tests sort of in conjunction with each other by doing different tests, you can indirectly gauge where in the infectious cycle you are. And I think that is what currently people are working on extensively to see by doing large screening in asymptomatic people to identify first, is the test sensitive enough to pick some of these up? And then number 2, what does that mean? Now, one final point about, these kinetics is that we're still trying to, understand fully whether that is the case. I think, Dr. Madoff said earlier that there are some immune responses that we have a really hard time tracking. So the serology test is one element, that's the antibodies. But there's also the innate immune system, there's, cellular-based immunity, and all these components may actually interact. So there are a lot of efforts going on to identify other immune reactions other than soluble antibodies and see how they actually contribute to the human response to the virus. But that is still, an ongoing, research field.
Thank you. I'm gonna go to Mr. Maloney. I got a quick question for you. I know we have 5 minutes left in the program. Let me ask a quick question to Darlene. Darlene, is it possible we can go over for 10 minutes? Seems like we have quite a few questions.
Yes.
Okay, so we are a lot. Is everybody fine with us going just a little bit over? All right. Pat, this question is directed to you. Um, and this is going to be a challenge. With the outdoor seating that is currently being allowed, has anybody thought about wheelchair accessibility and how do wheelchairs maneuver around the outdoor seating? Um, yeah.
Absolutely. Um, we look at the outdoor seating as an accommodation, and part of our review with planning, building department, we're all part of that team, the police and fire, and we look at that, and disability access is part of it. So if somebody is aware of a facility that is not affording somebody with a disability access to that environment, give us a call and we'll investigate it right away. It's part of what our expectation is. These seating is for all, and everyone should be accommodated at this time. and at all times.
Dr. Badoff, I think this question is for you. This is from CK Low. Many people seem to be visiting, and I'm assuming they meaning from out of state. Is it safe for people who have mostly been isolated to have contact?
So I'll answer that actually by first the sort of the legal answer to that, which is that anybody coming from out of state is recommended to quarantine for 14 days on return to Massachusetts, regardless of their level of contact out of state. And that's a rule that the governor put in place. So speaking as a state public health official, that's got to be my official answer to that. You are required to quarantine when coming from out of state, regardless of what your circumstances were out of state. And of course, you know, if you're getting here by public transportation, by public conveyance, there's a risk of exposure. Even if you're driving in a private car, there's people need to stop, and so there are risks. And you know, this is a question of balancing risks, right? And you know, any exposure, any close contact, as Patty mentioned, any kind of face-to-face contact, and particularly if it's for a longer period of time and without a face mask, increases your risk of exposure to COVID. And so you know, we have to balance the risks. And the one thing that I want to add about the risks is that the risk that you're assuming isn't just for yourself. It's for those who you subsequently may come into contact with. And so, you know, we are in this together, and protecting yourself from risks from someone from out of state or your next door neighbor is important in this situation. It's important not just for you, but for all of those who you have contact with, and for all of the people that your contacts may subsequently have contacts with. So just please keep that in mind.
Next question is from Kathleen Turner, and this might be for you, Dr. Leonard. Thanks for doing this presentation. If families are traveling into other states, are there recommendations for safety? One, and can you speak about the COVID antibody test? Would you recommend getting one? And the level of trust not transmitting based on results? So sort of a twofold question.
The traveling out of state, I'm not quite sure how to answer that, because you know, it depends on numerous things what you want to, you know, take on as your personal risk. I don't think that I'm the right person to answer that, because you know, you have to factor in, you know, why you travel. For example, you know, if there's, you know, someone sick in your family, I would prioritize that. If, you know, it's for pleasure, I would probably not recommend it, but that's just my personal opinion. Regarding the antibody test, should you get one? I would say there's so much information there that it is an absolute adequate and relevant question, because it's not just, yeah, go to Wikipedia and read about it and form your own opinion. It is extremely hard at the moment to make an informed decision. And I've spent, you know, at least an hour a day reading about, you know, new FDA approvals, new intended uses. And, you know, it is one test that can give you some information, but the information of whether you're antibody positive or negative has to be taken, you know, into account when you got the test. And that, you know, we still don't know what the best test is to identify the neutralizing antibodies. So there are some tests underway to really delineate whether some of the antibodies that are detected by some of the tests can actually clear the virus. That would obviously be the most relevant test, because then you could assume that you're immune, but we don't have good data on that. So getting the test is, I would say, currently mostly something to inform yourself whether you have had it or not. And I would caution to say that then once you had it, to make any kind of decision whether or not you should change behavior, because we don't know whether it's protective. And then on the other hand, if you're negative, you know, some people that we tested sort of had this idea, oh, I thought I had it. Oh no, this is so bad. I mean, you could reverse this and say, very likely for any downstream vaccination, that would be likely given to people who are negative. So that should both in turn trigger you to still follow contact precautions, wear your mask, and protect your status as it is. And the other part, which also leads to some confusion, if you're positive for antibody testing, there is a subset of people who do have an active infection while they mount the immune response, which is, an overlap. So that will also have some consequences. So the test is definitely not for fun. Some people said, oh yeah, let's go. And, some companies have offered that, $50, you can just walk in and get the test. And then, there's almost like, COVID testing parties. I would strongly advocate against that because, A, there's still limited supply. And on the other hand, what to do with this information is highly dependent on the context that it's used. For example, in the hospital, the use of these tests are in immune competent versus in immunosuppressed patients, and it means completely different things. So just randomly walking into, a commercial setting or ordering some of these tests online without interpreting it or being able to interpret it in the appropriate medical condition, I would, discourage people from that. It's, I don't know, I heard of cases of, chiropractors offering the testing as part of their, manual therapy session. That doesn't make any sense to me. I mean, there may be something that I haven't seen there, but, I would say ask your doctor, see what they recommend, but tailor to your person, tailor to your setting, rather than just getting the test and then having a free-floating result somewhere.
Dr. Meadows?
Right, and I just want to, as Joe has said, there really is not evidence at this point that having antibody on a test indicates that you're immune. And so I think it's really important to keep that caution in mind that antibody may predict immunity, and it may not. So just having the antibody, knowing that your antibody is positive, shouldn't lead you to act any differently at this point.
When I'm looking at the questions, and I have brilliant minds on panelists, and nobody has asked this particular question. So, I'm curious: can you get COVID twice? I mean, to me, this is just basic, simple question. Can you get it twice?
So I can tell you that's also ongoing. I don't particularly like experiments on human primates. Nonetheless, there is a very good and very well conducted study performed on rhesus monkeys, which are by immune system and overall, organ system and also immunology relatively reflective of us. We're also primates in a way. So that's the closest correlate. And in that setting, once you mounted a true immune reaction, that means an actual real antibody response, you cannot get it twice. The issue is, and that is probably explaining some of the data, you may have this infection as a mucositis, meaning it infects, maybe your nose, maybe your mouth, but you may or may not mount a full immune response. And that may explain some of these, symptomatic courses where you can find the virus, but then you may or may not mount an immune response. And without an immune response, you have no protection. And without the protection, yes, you can get it again. But those are two completely independent studies. I'm just providing the facts as far as I know it. I haven't done a full literature review on this systematically, but I think that is the best to my knowledge. But Larry, do you know? I think you're muted.
I'm muted. No, it's a question that we are grappling with. I would say in the public health department every day, because we do first, as you mentioned, we've only known about this virus for 6 months. And so, how can we know whether people who have immunity to it, how long that immunity lasts? So I think the question, certainly other coronaviruses people can get twice. And so that's some evidence, I guess. And so it wouldn't surprise me if people can get COVID twice. As yet, there's limited evidence.
Maybe one thing to tie the last question, this question together, like these random tests harbor one other risk. if you get the test in an appropriate health setting, it will go into your medical record. And that is the only way currently epidemiologically to figure out whether someone can truly get it twice, right? If you mounted an antibody response and then you come back next year or, in a couple of months and then you have it again, that would be an indication that there may not be immunity. So that argues strongly for following, what's officially considered, your electronic or whatever health record you have, rather than doing commercial testing sort of off limits as sort of a walk-in that is not documented, etc.
I have another question, and then I'm gonna go ahead and proceed to wrap it up. Have a good night, Dr. Baloff. I know you have to leave, but I appreciate your time.
Thank you
So,
very much. Good night.
good night. So one last question that I'm gonna answer, and then I'm gonna present two more. Um, so what types of data are being used to identify potential contacts in Brookline? So this question came from Lauren Kane, and I would just say we get data through Maven, and that's usually the person that the individual that's possibly infected. We actually contact them and we interview them to find out, who they were around, exposure, where they work, they live, household contacts, etc. What you should see, and I think there's a better way to do the contact tracing part, and I have been working with um, an app called Pathways, and it's an app that eventually, is working in a backdrop now, but hopefully we can get it off the ground and it's available to citizens of Brookline where they would be able to tell hotspots of where they have traveled and if they was in contact with somebody that actually traveled to a particular area. So I think that's the wave of the future that what you would see. I had a question about nursing homes, but Dr. Madoff is off, so we will bypass that one. But I have one last question for the panel before we call it a night, and I think it's a fairly important question. So COVID is here. I don't foresee COVID going away anytime soon. So do you feel that it's just going to be the norm that we're going to be wearing masks well into the future, just as you see in other countries? That's going to be a normal day of life for people in Brookline, and we're going to social distance, but we're going to do it beyond when we have a mask, when we have a vaccine available. Will that become the norm? It's a deep question.
You want us to foresee the future, Dr. Jett.
Yes. Yes.
Let me just jump in where I think the one thing I'm pleased to see as a former health educator is, people are now following good sanitation, the washing of the hands, fundamental thing. Hygiene, that term is coming up again from years ago. And I think people are more aware and cognizant as to the benefit of following these good practices. Will it be to the level where we have to wear the barriers on the face and social distance all the time? I hope not. But I do believe we still need to practice good hygiene. That's a fundamental public health protective step. And we're seeing more of it. People are recognizing it. And I think that's with us and will always be with us for the long term.
Yeah, I think I totally agree. I think it's unpredictable how this virus will be and if the vaccine, how effective it'll be. But I think in the meantime, we are getting more information about it. And I think we need some trusted sources of information because that is a problem in our country now of people are feeling confused about where to go. And I think the public health department is a trusted source. And I think it is important, as Pat said, to get as much education as possible out in the meantime. But as far as how long it'll be, I think it's so unpredictable.
Dr. Nurse?
Yeah, it's a very good question. So it's a challenge, right? And with every challenge in life, you have to adopt. Here, the very unique challenge is that you have to keep adopting. That is almost like, the meta level. Like you can read today and you think, oh, now I understood the next thing, and it is gonna be thrown over tomorrow. And I think adopting to this, like almost constant change, is extremely challenging. So I would caution not to adopt to like, the next rule immediately, but really exercise, your logical thought. Think about it, whether that makes sense or whether it just seems like, one of those news that will be irrelevant in 3 or 4 days. And I think we may have not really seen that you're challenged in a way to constantly adopt, which we all do in all of our lives, right? But what I mean here is that we're currently faced with something, do I like wearing a mask? No. But do I do it? Yes, because it makes sense. A lot of people have demonstrated that it helps. And I think, keeping this attitude is very draining. And I think sharing that and keeping a good emotional state to face this constant challenges is very key. So I think it's more like an internal struggle than, whether one prediction is right or wrong. I think we can, withstand quite a bit if we're prepared for that. But that's a challenge. What do you think, Dr. Jet?
Well, so I'm gonna bring up a new term because I often make up these terms that it's not in a dictionary. So Pat, I know you're a whiz, but I don't want you to look this term up in a dictionary. So this term is called vigilant.
What is it?
Vigilant. So it's being a villain and vigilant about everything we do. And I think we have to do that. So I made this term up when I was in Iraq, and everybody used to laugh. And but I meant it. We had to be um, hard charging at dealing with the enemy at that time, and protecting our lives and making sure we came home safe every day. So my job, I had 200 soldiers under my leadership in Iraq, and my job was to bring everybody home at the end of their shift. I think we need to use the same method in terms of going after COVID. And we need to use the same method in terms of dealing with racism in America. We need to be vigilant. It needs to be long term. It needs to, have a lot of systematic approaches to break down the barriers. And I would just say, public health, people often they overlook and they talk about first responders and frontline workers and hospitals, but they forget about public health. That it's the policies that we put in place, it's the epidemiology that we do, and the public health measures that we do to keep people out of the hospitals. It's the reason why you have hand sanitizer. It's the reason why we tell people to wash their hands, to do social distancing, to wear a mask. It's public health measures that save lives. It saves more lives than one-on-one of any doctor. It, just like we don't have enough policemen on earth to commit every crime. We don't have enough doctors in the world to stop and treat every patient. So we have to use public health measures. And Brookline Public Health, first, I want to give thank you to all the public health professionals across the country and across the world because you know, it's not just done at the hospital level, it's done in the public health department. That's where the public health funding has to be, is boots on the ground. It's doing all the contact tracing. It's doing all the health education and promotion. And we have to stay vigilant on that. And also, I want to say the health department, as we continue the future working on racism, we have public health forums coming up dealing with racism, and we want the community to continue to join us. So I want to thank um, panelists today. A lot of information. Pat Moya, Mr. Maloney, Dr. Nurse, and Dr. Madoff. I appreciate everybody's time today. And if I didn't get to answer any of your questions, I'm so sorry. But we do have Darlene on the line, and she will continue to populate those questions, and we will post them on our website. So everybody have a good night. If you participate in the town meeting tomorrow, good luck to you. I should be there. Thank you, and I appreciate everybody's time.
Thank you, Dr. Jack.
Thank you very much.
Good night, everybody.
Good night.